Welcome back to this lecture series on aviation and flight physiology. This is the third and final part of this lecture series, which is based on a lecture previously given by Dr. David Cooksley, and to which I have modified some of the content and re-recorded the sound to better match this particular delivery format. The quality of the content, however, remains as per David's excellent original lecture. Just to recap, in the first part of this series we looked at atmospherics and the basic gas laws and how they impact on aeromedical retrieval, whilst in the second part we looked at more applied flight physiology and the transport environment and how this impacted on our patients. In this third and final part of this series, we're going to focus a little more on the transport environment itself and its impact on both our patients and on the aeromedical crew looking after them. The transport environment itself throws up a number of specific challenges to both patients and to the medical crew working in that environment. These include all those listed here, and we've already spent a fair bit of time discussing pressure changes in the first and second lectures of this series. In this lecture, we're going to spend a bit more time looking at some of these other environmental factors, including accelerations, vibration, turbulence, noise, cabin issues of space and lighting and heating, as well as some of the psychological effects of flight. All of these environmental factors contribute to the many and unique challenges of aeromedical retrieval. We'll start off by considering the effects of acceleration, primarily its effects on our patients. So before we do that, we need to consider what acceleration actually is and how it occurs. Acceleration is defined as the rate of change of velocity per unit of time, and typically can occur in one of three fashions. Acceleration can occur in a linear fashion, that is, a change of speed in a straight line. It can occur in a radial or centripetal fashion due to a change in direction, or in an angular fashion, which occurs when there is both a simultaneous change in speed and direction. It doesn't take much imagination to realise that all three of these types of accelerations can and will occur in our aeromedical environment. Clinically, the specific type of acceleration is of less relevance than the fact that it actually occurs and the impact it can have on our patients. Accelerations are referenced according to the long axis of the body. So for our patients, it will depend very much on the orientation they are secured in the aircraft and their body position as to how we reference it. In the aeromedical retrieval environment, most effects of acceleration will be felt in fixed-wing aircraft on landing and takeoff, as well as in turns, although generally in this circumstances to a slightly lesser extent. Effects are generally much less notable in rotary wing aircraft and are more of a factor in fixed wings, though will be variable depending on aircraft type, runway length, prevailing weather conditions, etc. etc. So whilst this slide looks to quantify the G-forces felt in various activities, it is worth remembering that standing directly upright, by definition, the soles of our feet experience 1 G of force. At most, our patients should be experiencing somewhere between 1 to 2 Gs during takeoff and landing. The big question, however, is to consider what impact this G-force will have on their underlying pathophysiology and what, if anything, can we do to mitigate this. The patients most at risk from the effects of acceleration and deceleration are those at risk of acute cardiovascular decompensation, usually due to sudden fluid shifts, and also those with head injuries due to sudden changes in their intracranial pressure. Whilst there is some debate in the aeromedical literature about the optimal positioning in aircraft for these patients, particularly in fixed-wing aircraft, the reality is that whilst transverse or east-west orientation would seem to be physiologically optimal, unfortunately in the vast majority of situations this is simply not practical to achieve. Given that transverse loading or securing is out of the equation, the question then really comes down to, should the patient be placed head first or feet first, as well as what variation should the head be, up or down. In truth, given the forces are generally opposite depending on whether the aircraft is landing or taking off, what one loses on the swings is generally gained on the roundabouts, particularly without the ability to rotate the patient position mid-flight. And even if we could achieve this, the impact on clinical outcome is generally still unknown about the effects of the G-forces on landing and takeoff. All of this is actually much less of an issue in rotoring aircraft with its lower G-forces and generally vertical takeoff, as well as the fact that in many setups the patients are loaded in a transverse position. The patients that most need to be clinically managed through takeoff and landing are those with critical hemodynamic compromise, where the more sudden fluid shifts that can occur with takeoff and landing can result in sudden and quite significant cardiovascular embarrassment, often at a time when the team is least able to do anything about it. This needs to be both predicted and prepared for. And it's not just in landing and takeoff that these considerations must be thought about. Loading systems with steep exit and entrance ramps, such as those shown here, have been responsible for sudden and sometimes catastrophic cardiovascular collapse, including cardiac arrest in patients who have to spend a period of time head up and feet down and to begin with are in a fragile hemodynamic state. Again, it is vitally important that patients are carefully monitored during any movements and that the effects of a sudden change in fluid can be taken into account during all patient moves. The next topic we'll consider is that of vibration. Most vibration comes from the power plant and rotary system in rotary wing aircraft, which is generally much more of an issue than vibration is in a fixed wing aircraft. Although vibration will be variable throughout the various phases of flight, it is much more pronounced on startup and takeoff, in transition to hover, and during landing and shutdown. Vibration will affect patients directly with concerns around clot disruption, fat embolism, exacerbation of pain, especially in limb fractures. Other clinical consequences are its effect on crew, with it being linked to fatigue, as well as its effects on medical equipment, especially monitoring equipment, where loss or severe artifact on the ECG trace, saturation probe artifact, and outline trace discrepancies can result in significant periods of the patient being unmonitored. Even automated non-invasive blood pressure monitors struggle with excessive vibration. Ventilators can be an issue, with excessive vibration causing breath triggering, depending on what the flow trigger sensitivity for the ventilator is set at as well. As well as this, vibration has been linked with the areas detailed on this slide. Consider the effects of sustained exposure to low-frequency vibration on crew and patients directly. This can have a number of deleterious effects, as highlighted on this slide, and the effects on thermoregulation will be particularly deleterious in the elderly and neonates when coupled with their already intrinsic thermoregulatory weaknesses. Patient care is also directly affected, with their ability to undertake a physical examination often quite significantly impacted. Palpation of pulses is difficult. Observation of chest wall excursion becomes compromised. Abdominal palpation deteriorates to pure guesswork, and auscultation becomes almost impossible. As well as this, the effects of vibration on equipment, as we've previously mentioned, is not insignificant. Automated BP cuffs fail, ECG leads become unreadable, and oxygen saturation probes fail to pick up or give false readings. And in more complex situations, temporary pacing wires have been known to fail to capture due to the vibration causing the lead to move away from the ventricular wall. And it really goes without saying that in these conditions, all equipment must be well secured to prevent injury to patients and crew should the vibration cause them to come loose as well. An unfortunate part of aeromedical retrieval can be the unwelcome impact of turbulence. Whilst turbulence can have similar effects as vibration, it comes with additional consequences, primarily with the appearance of motion sickness in susceptible individuals, as well as the not insignificant psychological effects that can result. This will be especially apparent in those who are already feeling vulnerable because of their illness and injury. This can be of particular impact on children, especially if they've been parted from parents or loved ones for the flight to the receiving centre. Interestingly, helicopters tend to tolerate turbulence slightly better than fixed-wing aircraft, primarily due to the ability of the rotor blades to take out a lot of the energy inherent in the turbulence itself. As we've already mentioned, turbulence can lead to motion sickness, though in many circumstances patients will have motion sickness even without the effect of turbulence. And this can be a significant factor also for the aeromedical crew. Motion sickness can be exacerbated by turbulence. But other factors that influence it are the position of the patient or crew in the aircraft and the direction the individual is facing, as well as their ability to get references outside of the aircraft. It can in fact be quite difficult to manage, with many of the remedies available not really appropriate for medical staff trying to undertake critical interventions. Prophylactic maxilon and ondansetron is pretty much pointless, with other antiemetics having variable effects. Probably the most useful anti-motion sickness drug is promethazine or Phenergan, but this is generally not practical for most of our patients, and especially not practical for staff. Our research seems to support the use of hyoscine and cyclizine, as both being generally effective due to their actions on receptors in the vestibular apparatus. But again, often they are not the most practical, either for ourselves or our patients, due to their side effects. Moving on from turbulence and motion sickness, we should start to consider the impact of noise within the aeromedical retrieval environment. It is in fact a major issue and can significantly impact on our ability to concentrate as well as to communicate. This is especially the case with tasks that require constant vigilance, such as observing monitors and keeping track of ventilator parameters. The most obvious impact on noise is our ability to monitor alarms. This impediment can be overcome in some systems where the alarms are wired into the aircraft intercom, and it is the same intercom system which also allows us to communicate effectively with our colleagues as well as our patients, depending on whether they've been connected up. It is for this reason that all crew should be on headsets with microphones, and not just the aviation part of the crew. The effect of ultrasonic noise, which is the noise above hearing threshold, generally at frequencies greater than 20,000 Hz, is particularly common around jet engines. And this noise itself can result in side effects such as fatigue, dizziness, headache, nausea, tinnitus, and again our old friend motion sickness. This almost constant exposure to noise is the reason it is mandatory that we use hearing protection, both to decrease fatigue as well as for our long-term health and welfare. Moving on from noise into the specifics of the working space. The generally cramped and confined spaces of the transport environment itself, often coupled with poor ambient lighting, mean that our ability to assess and manage our patients will often be compromised. As well as this, it will limit our ability to respond to acute or dramatic changes in the patient's clinical condition. This is why it is generally advocated that all critical interventions are undertaken prior to transport, that appropriate monitoring is used, and thoughtful consideration is given to possible causes of patient deterioration that could occur en route, and actions are taken to minimise the chances of this occurring before departure actually occurs. Issues around ergonomics, body posture, and access to patients are nicely illustrated in this and the next slide. Tight spaces, awkward angles, need for headphones are all illustrated. The same problems are illustrated in the rotary wing environment in this now somewhat old but still very relevant photograph. Tight spaces, difficult ergonomics, limited access to the patient, need for hearing protection, and communication devices can all be evidenced. As well as the physiological and physical environmental impacts of the aeromedical retrieval environment, it is also important to consider psychological factors as well. Aviophobia, or fear of flying, is a not uncommon issue, and for patients who suffer from this, it may well compromise both their assessment and management. The result of this patient fear may in fact appear as signs of shock. Patients may appear agitated, combative, diaphoretic, tachycardic and tachypneic, which rather than a manifestation of physiological shock requiring urgent medical attention, it may just be the effects of profound fear. This psychologically mediated sympathomimetic surge may also exacerbate underlying medical conditions such as angina and significant hypertension. It is at this point this lecture will conclude. In this part of the series we have touched on acceleration and g-forces, vibration, turbulence, motion sickness, noise, cabin ergonomics, and the psychology, or more specifically, fear of flying. Over the 3 parts of this series, we've covered a lot of territory with respect to the transport environment and flight physiology. In terms of its clinical impact on your patients, this can probably best be summarised in a couple of key points. Take this knowledge and think ahead about potential flight environment effects on the patient and their illness. And the second point to make is, your ability to intervene in patient care in the back of the aircraft will be limited, so do what needs to be done before you leave. Thank you all very much for your time. I hope you've found that these podcasts have been useful.